First spotter, ma'am. Team 1, your first spotter. Your time starts.
7-year child with 2 weeks old burns 37%, mainly involving the lower limbs and part of the abdomen. Other parts are not involved. It's open. The questions can be started by panelists. 15 minutes given for panelists to ask questions. Approximate 15 questions may be asked, 1 mark for each question. Correct answer.
Okay, so team 1, I think we start with team 1.
Yes, yes, ma'am.
So team 1, what would be the degree of burn when you see this patient? What do you think is the degree of the burn?
Second degree deep and third degree burns involving the abdomen. It is third degree, ma'am. In the inner part of the right thigh, it is looking third degree. And second degree deep in the lower part of the right lower limb and in the left lower limb. Towards the left leg, it is second degree superficial.
Okay. And what could be the other diagnosis that you can see apart from the depth of the burn? What do you think is the state of the burn wound?
It appears to be old burn, madam, more than 2 years. Eschar has formed.
It is a 2 weeks old burn.
Eschar has formed, madam.
Yes. So what do you think you would do with this? How would you manage this patient?
We have to excise the deeper parts of the wound and plan for tangential excision over the deep dermal parts and put cover for the raw area.
Will you be able to do tangential excision at 2 weeks? I mean, where would you be excising? Which areas? Because you said that the lower abdo and both the thighs are.
Deep dermal areas we have to do tangential excision.
So how long does it take for the deep dermal burns to heal? Superficial dermal and deep dermal?
Superficial dermal takes 2 weeks to heal, ma'am. Whereas deep dermal, it takes around 3 to 4 weeks.
3 to 4 weeks to heal. Okay. Dr. Brijesh?
So this burn, you see there are certain areas which are involved. So what will be your precaution while dressing these burns? And will these burns will have a more chance of infection? And why?
Yes, sir, these burns have a high chance of infection because they're adjacent to the urine outflow tract and also nearer to the anal canal, which there will be continuous daily contamination of the adjacent burn areas. And also they are very deep, so more chance of infection will be there.
So how will you, what will be your strategy for dressing in such burns?
For urinary tract, we'll put a Foley's catheter, sir, to prevent the leakage of the urine.
So he's asking, how will you dress these burns? What kind of dressing would you use for such burns?
In the deeper areas, we can put eschar penetrating on topical agents. And
which would be?
Mefenide acetate will be eschar penetrating. Topical creams are available, so that we can put.
So do you have mefenide available in your country?
Not available.
So whatever's from what's available in your country, how would you dress these wounds is what Dr. Brijesh is asking you.
We'll put silver sulfur diazine. We'll put over the eschar area, ma'am. That has a comparatively less effect compared to mefenide on penetration of eschar.
Okay, one thing, because scar is there, how will you manage the scar? You said mephenide. Mephenide is not available practically. We don't see it. So how do you get rid of this scar?
We can do a surgical debridement of the eschar, sir.
Mm-hmm.
And since this is a child, there is chances of bleeding also, and blood transfusion will be required during surgical debridement. There are other methods of debridement like hydrotherapy, mechanical like hydrotherapy, then enzymatic debridement using papanuria.
What other modes of debridement? One you said was enzymatic debridement and
Mechanical debridement,
okay.
hydrotherapy using Vasajet,
Mm-hmm.
and surgical debridement, sharp dissection, sharp debridement with the
Okay, supposing that you're not able to excise this wound, patient is not fit, and it is a very tightly adherent eschar, what else can you do? Tightly adherent eschar.
ischia.
Like in this case, only in one area it is separating. Rest is very tight. Okay, how will you surgically excise it?
First, we'll give tumescent solution, madam, under the eschar. Then we'll keep multiple incisions over the eschar in multiple places. Then sequentially, excise all the eschars.
Sequentially, how will you do it? You've already given multiple incisions. What is sequential excision?
Like
Excision up to the viable tissue, subcutaneous fat.
So what do you do that with? How do you do that? How do you do tangential excision?
With this power dermatome or graft handling, skin
Okay.
graft handling.
And so what is the difference between a tangential excision and a sequential excision?
In tangential excision, we'll be layer by layer, we'll be shaving the dermis till the punctuate bleeding of the viable tissue is seen. In sequential excision, we will remove the whole of the skin till the subcutaneous fat is visible, which is viable. In sequential excision, there may be chances that the viable part also got removed. But in tangential excision, we make sure the excision is till the non-viable tissue is removed.
Dr. Lakshmi, we are not supposed to say anything, no? No corrections, no this thing.
No, if you feel it is wrong, you can pass on to the second team.
Acha, okay.
So they will get the mark.
Okay, second team. Can you improve upon this? Is there something wrong with this?
Ma'am, tangential excision is done with the help of a dermatome or a Humbee's knife, where we excise in different at different levels tangentially, so that till the healthy bleeding points are seen, which is a site, which is indicative of a healthy bed for which grafting can be done.
See, when will you call it tangential excision? What is the bed? You're all both saying the bed. What is the bed?
Ma'am,
Punctate
Punctate tangential excision.
bleeding is coming out from the
What is the kind of burn which is an indication for tangential excision?
ma'am, acute burns which present.
Is tangential excision indicated for all degrees of burns?
second degree deep and third degree, and mostly preferred in the third degree burns. And tangentially, we can excise the dead viable tissue to remove all the dead viable tissue, and we can do this tangential excision in within 5 days.
Within 5 days of burns.
With the covering of the wound area with the STSG. If the wound area is small, and if wound area is too large, then we can do the autograft with the sandwich graft like techniques.
So do you have any other modalities of covering these wounds if you don't have a skin bank and you have a larger area?
So we can. So do we have to answer? The team one will answer.
Dr. Lakshmi, the question goes back to team one, or can they answer?
Team one only, sir. Team one.
Team one. Okay. So, team one, if you have these wounds and you're excising, you're doing a tangential excision and you have a larger area, you don't have access to a skin bank or autograft. Do you
Team
have
one
any-
should answer this.
Yeah.
Yes, sir.
Do you have any? I mean, how do you cover these wounds then?
That like cadaveric allograft we can put, sir. Otherwise, if it is not available, we can go for artificial skin substitutes and biological dressings like collagen we can keep, and amniotic membrane also is another option in case of larger areas where the autograft resource is not available.
Can you be specific with what kind of dressing which can actually serve your purpose of evaporative loss and coverage? So if you don't have access to autograph, what would you prefer? You have no financial constraints.
We have a collagen membrane or amniotic membrane we can put, sir, in case of.
Team B,
So we can use Integra for covering
Acellular dermis material,
and or
Integra.
material.
yeah. So how does it help further?
Sir, it's help in the aspect of the covering the wound area with the prevent the evaporation of fluid, maintain the electrolyte balance, maintain the protein loss, and preparing the wound for the skin grafting, and skin grafting. And if we have limited area of the donor, we can do the mesh grafting or small patchy graft.
The Integra or Matridum, they have collagen with it. So they can act as temporary wound coverage or a permanent wound coverage as well. So they cause when they act as a protective layer which prevents protein loss and heat loss and maintain the temperature of the body. Also, the biologically the collagen undergoes reorganization in which the host's collagen gets integrated and the collagen within the integra dissolves and is replaced by the host's collagen cells. So it acts as it also side by
Please
side forms a
brief.
bed.
Only 3 minutes are there.
So
It forms a bed for
I'll interrupt
skin.
you said two things, Integra and Matridum. So are they on similar lines or they are different products with different characteristics?
Sir, the different products with the different characteristic.
So
The
they
main
cannot be-
purpose is to acellular dermis we have to put to cover the area if a financial restriction is not there.
Okay, just mention one difference between the two dermal substitutes.
I think Dr.
That's-
Farooq and
Achha,
Mago also should.
Dr. Omar has joined.
Yes,
Yeah,
ma'am.
yeah.
Yeah,
Good evening.
then
I'm here.
Even
Ah,
Mago
you
sir
want to
is
ask
there.
one question?
Yeah, yeah.
Yes.
Dr.
I hope
Prakash.
I am Professor Chaudhary. I want to intervene, Dr. Farooq.
Sir,
Yeah.
time after
Yeah.
15 minutes, sir.
Yeah. So I hope now I am not talking. What I intervened is the questions answers should be very brief. It should be very brief so that we can
Yes.
within time.
Yes,
That's
sir. Yes. Because 15 marks you can get. If you answer long period, you will lose the marks.
Yes, that is the point.
Umar, please. Your
Yes,
question.
Dr. Prakash, seeing
Sharp
the
question,
burn like
sharp
this.
answer.
Yeah. Seeing the burn like this with the raw area. Dr. Prakash, are they there? Are they
Yes,
there?
sir.
They are hearing. That
Yes,
is
sir.
audible.
Yes, sir.
Could you have done something that this should not have happened?
Sir,
What
early
could
time,
have been done
early,
that you could have avoided D burn, third degree burn? These are the D burn now, no?
yes, sir.
Could you have done at the acute stage?
Yes, sir. Early
Can
tangential excision.
it be avoided some way? It can be avoided.
Yes, it can
Or
be avoided, sir.
so
Early
what
tangential excision within first 2 to 3 days.
what could you have done?
Early tangential excision, sir. And
Early
followed by skin
tangential.
grafting.
Anything else?
Sir, you ask question instead of expect. Don't expect.
Okay.
Mago, Vishal
Genitalia,
Mago.
how do you cover the genitalia? Genitalia are also burnt. So what will you use?
Team 1.
Team 1, please.
Next. Here.
Time.
Time is over.
Yes, ma'am. 15 minutes is over. Now
10
we
minutes
can go to
over.
the moderator.
Okay, moderator questions, please.
Yeah, thank you very much. Well, apart from the question I'm going about the tangent selection, I have to just find it out because you have already answered the questions and must have been also marked by the judges. Now, the tangent selection, in fact, started in 1954 by Jackson. And
Sir,
Jackson have
please
two.
ask questions, sir.
Son, what I am asking is, how do you know the depth clinically of this patient at the earliest? Clinically, how do you know the depth? Is there any test, clinical test?
Blanching can be done, sir. If it is blanchable and if it is reddish, it indicates
No,
superficial.
clinically, any objective test you can do.
Team 2.
Or you can do any scanning.
Sir, we can do pinprick
Sir,
test to know
ultrasound and laser.
the pinprick
Yeah.
test clinically
Ultrasound.
to look for the if it's painful, it's a superficial burn, second degree. If it's painless, it's a deeper burn.
Okay. So what about who started this fast tangential excision?
Zora Jalsokovic of Yugoslavian surgeon.
Okay, very good. Then what are the, I wanted to know, these patients must have been treated properly at the earlier. Then do you know what are the fluid formulas for calculating the fluid management of this patient?
Sir. Confined to wound only, sir.
Okay, is okay. Madam is okay. Thank you so much.
Thank you,
Okay.
sir. Thank you. Judges and other seniors in the audience. Judges, please. P.V. Sudhakar, sir, Dr. Jayaraman, Dr. Keshwane, Dr. Sanjeev Uppal garu.
Yeah,
Sudhakar, sir.
yes. My suggestion to the participants is to restrict to that particular case, don't go into the past, as to how to manage from that point which has been given in a picture. Okay, henceforth also restrict yourself not to the past but to the present and as to what you're going to do now. That's only that's a suggestion to
Sir, any questions?
the others. No question.
From my side, I would like to ask the question that lower limbs are involved. That specifically, it is kept to know what are the problems you come across in lower limb burns. What are the main problems if lower limbs are involved? So how you will tackle that?
Ma'am, the main problem will be contractures at the popliteal region and the hip region.
No. Management acute case, not the chronic case or a future. What sir also told the same thing.
Ma'am, in case of increased compartment pressure, compartment syndrome can occur.
Yeah, if it is circumferential burn, good. 1 point end. What are the problems? 4, 5 you can tell.
Wound infection due to colony.
That it anywhere it can happen.
What is more important than that
Yes.
if both the lower limbs are burned?
Lower limbs are burned. What is the problem?
What is the main problem?
Leading, no leading.
That the
DVT
other team is answering.
Ma'am, high chances of DVT.
Yes,
Not in a
that
child,
is one thing.
7-year-old child, no DVT. Something more
But
important.
immobilization and any central line is put infection.
Pressure source will
There
be
is
outside.
possibility in lower limbs.
Particularly in this case, when you manage this case, what will be the problem that you will be anticipating?
What is the main problem in lower
Donor
limbs?
Donor area.
Yes,
is
that is
one.
the first problem. So you cannot prepare the entire wound at a time. Okay. So you should prepare staged wise and a lot of other things required. So that is most important.
Okay, ma'am. I will move to the next quarter, ma'am.
Okay, just a minute. Dr. Lakshmi, I think there has been some miscommunication from, to our residents from Sabdajang because
I already shared the link.
Yeah. So I have asked them to join just now because they were not given the intimation regarding the joining, which team has to join, because there were two teams. So
Oh.
none of them got the intimation. So
No,
I
no,
think
no,
one
ma'am.
of the team is joining now.
No problem. I already told them to decide and give information to Rohit.
Yeah, they were waiting for confirmation from your side. But
But
anyways, I've
I-
asked them to join, so please include them in the quiz later on. Not
Yeah,
in-
yeah, yeah. Rohit, you note down their names.
Sure, ma'am. Sure.
Yeah, yeah.
Okay,
Okay,
ma'am. Moving to the
next spotter, second spotter, you please keep the time, Rohit.
Sure, ma'am.
Lakshmi,
Uh,
can I speak something?
Yes, sir.
yes, sir.
I'm just asking if the question is not being answered by both the teams. Can the moderator or someone tell that what is the answer of those questions?
Which question?
The question of the tangential and sequential has not been answered.
Sir,
So you have to explain them.
no. The remaining spotters also, there are questions related to this. So, shall we give that chance and at the end of the teams, we will elaborate what are not answered.
Okay.
Shall we, sir?
Okay.
Okay, ma'am.
Yeah.
I will move to the next spotter.
Team 1.
Diagnosis.
Be fast.
Post contracture of the neck involving hypertrophic scars extending to the anterior chest and abdomen, and anterior axillary contracture of both upper limb.
Okay.
Grading of the contractures.
Grade 2 with the Archer classification of grade 2 contraction.
Okay. What would be the
axilla will
degree
be
of
1
burn
to
in this case? What would have been the degree of burn in this case?
Deep burns, ma'am.
See, as a plastic surgeon, you have to be more elaborate rather than just saying deep and superficial.
Third degree burns will have, ma'am.
Full thickness burns?
Yes, ma'am. Full thickness burns.
And do you think that they are grafted or is it healed only by secondary intention? Do you think full thickness burns of this extent?
Grafted.
One minute. Do you think that full thickness burns of all this extent would have healed like this?
No, ma'am. Grafting has been done.
Yes.
Okay. Then
Grafting over the anterior.
the entire area would have been full thickness burn?
No, there are areas of second degree deeper burns also in the abdomen region and thigh region, and over the sides of the neck and upper limb.
Okay. Is this a primary contracture or a secondary contracture?
Secondary contractures.
Why secondary?
Occurred after skin grafting.
What I mean is, it is an intrinsic or an extrinsic contracture? Simple question.
Extrinsic contraction. And
which
Other
one
team?
is in eccentric?
Both intrinsic and extrinsic are there.
Next team.
The second degree deep burns with the grafting is done, and both are the primary contracture in the bilateral axilla and the neck also. And in the thigh region, in the mid lower peak, there is a in the thigh skin graft skin graft scar is there.
Ma'am, there is extrinsic contracture involving the face because of the intrinsic contracture of the neck. It is causing pulling down of the skin of the face and the ears. causing downward direction, causing pulling of the facial skin. That is the extrinsic part.
Okay. Dr. Mishra? Dr. Brijesh?
This is third-degree burns only, treated with sandwich graft. So that can be accepted.
So how will you, what will you explain to this patient about further management? Team 1, Team A.
One.
Team
How will
one.
you treat him further, or your treatment is over?
Sir, we'll explain to the patient that
Sequential.
sequential contractor release and grafting should be done. First,
What
we'll
will be your sequence of release?
Sir, first we'll release the neck contractures.
There are multiple contractures. What will be your sequence?
First, we'll release the neck contractures. Sir. Then we'll release the axillary contractures.
Can you release the neck and the axilla in the same go?
No, ma'am.
Because it's a continuous.
Yes, sir. No. Be
No,
fast.
No, ma'am.
No.
What is the reason? Why so?
Because the
Second team.
positioning will be difficult in this case. Axilla has to be kept in the full 90-degree abduction, and the neck has to be kept in the extended position. And if we exercise and graft both these areas together, the graft pull will be there towards opposite sides. So it is not advisable to do the neck and axilla together.
Okay.
Okay.
Dr. Omar?
Yes. How will you intubate this patient? How will you give anesthesia?
We can try, initially we can try with the fiber optic tube insertion and intubation. If it is not possible to see the vocal cords, then we have to go with a sedation and awake intubation after release of the.
You mean with fiber optic, you will not be able to intubate?
If it is not possible, sir, if still the vocal cords are not visible and adequate extension is not obtained, then we have to divide the
What extension did you
contraction.
expect? What extension did you expect? Patient is having the neck contracture like this. Now anesthetic is there. He has to intubate the patient. What are the ways?
Sir, we
Will
can
you
do
go directly to the nasal fiber optic?
No, ma'am. We can use sedation and put a laryngeal mask. We can release the neck contracture. Then we can keep a temporal dressing. Then with the neck extension, we can re-intubate the patient again. Then we can proceed with the procedure.
Okay, one investigation preoperatively that you would want to do for the sake of the anesthetist for a PBC neck.
X-ray of the neck to see any tracheal deviation.
Okay. Dr. Mago?
What are the options in release of axilla?
Confined to neck only, Mago.
Only neck. So what are the flap options in the neck?
Trapezius, pedicle trapezius flap we can put, parascapular flap we can put.
Parascapular.
Extended parascapular.
And give chance to other team also.
Other team?
Next team. Team 2.
Multiple Z plasty.
Ma'am, Z plasty release and
Free flap is the one
square
of the
flap.
option.
Square flap we can do.
Episode.
You are saying that you would be able to do Z-plasty or square flap in this neck contracture? We are talking about neck contracture, not axilla.
Ma'am, the donor area is restricted because the sandwich graft is done in the upper chest region. And
So what?
There
are no donor areas. It is quite visible. What is your plan of management? Okay.
Ma'am, it was incisional release and
assess the defect.
And assess the defect and then put a grafting, split thickness in grafting.
So then you are saying that there
They
are
are
no...
asking only flaps. So name the flaps for the case.
Ma'am, supraclavicular flap.
Is it available there?
Yes, sir. The area is not burned and it's not involved in the field. So
I don't think
Yes.
so.
Vascular supply of the
Right side.
supraclavicular flap.
Any other option?
Next question.
Cervicodorsal.
So this question has gone to both the teams. No?
Second team answered the flap. So team 1, next question has to face. Listen to the question and sharply answer to the question.
What kind of graft would you want to resurface the defect with?
Ma'am, intermediate split thickness graft.
Okay, why not a full thickness graft?
That much area of this may require a large area of the grafts, and
What would be the best option for a neck contracture release? Resurfacing the defect. Best option, ideally.
skin graft.
Skin grafting.
Why not a flap?
In case of we can put also very ultra thin flaps, ma'am. Otherwise, it will be bulky and neck movements will be affected.
Okay, any other
And
option
contour,
that is there?
Any recent advances?
You can add something before grafting the.
No,
this
team
the-
2 is waiting.
Team 2.
Answer.
I think
Team
next
2
time
is
the question should be put to team 2 first.
the
Because
3
they are
sets
only-
of spotters are there, madam, for them.
Okay.
we can exercise and put a dermal matrix and followed by
Yeah.
skin
Grafting.
Yeah.
Yes.
Madam, can I intervene? Already we
No,
have
sir,
finished.
no, sir. Time still it's there, I think. What, Rohit?
Rohit, what is the time?
Sir, 5 minutes. Still,
What?
yeah,
No. Okay.
Still 5 minutes.
still 5 minutes. 5 minutes more.
Okay. 5 more questions can be asked it for this spotter.
What is the advantage of using a dermal matrix versus using just a split skin graft?
In case of dermal matrix, there will be less secondary contractions can occur in case of skin graft alone, if we put, and there will be better contouring of the surface
How?
because it will form an artificial dermis if we put a skin graft alone, and that can cause more secondary contractions.
Liability. Actually, contouring will be the same.
Team 2?
ma'am, there will be improvement in the texture of the graft and there are high chances of graft survival if we place a acellular dermis with the
You mean to
improvement.
say if you put it directly on a release neck, it will not survive?
Ma'am, it will survive, but there are high chances of improvement in the texture and the pliability of the graft if we use acellular dermis along with the skin graft.
And what else?
And ma'am,
Data is suggesting there is a less chances of hyperpigmentation.
Improvement in the pigmentation.
Improvement in the pigmentation.
What else?
And
The
less chances of secondary contracture of the graft because of the dermal acellular dermis placement.
What is secondary contraction due to?
First team should answer.
Team
To
1.
the dermis.
What is secondary contracture? Madam is asking.
Uh,
What is it's due to what?
It is due to the dermal content of the skin graft.
Is it
Team
the
2?
secondary?
Team 2?
Team 2 answer.
secondary contracture due to the bilateral axilla is also
No.
contracted.
Ma'am,
What is
it's because of the
secondary
dermal, the amount of dermis which is inside the recipient area.
Both are
so
wrong.
Both more amount of dermis, less is the contracture.
We are not asking you what will prevent secondary contraction. We are asking you what is the secondary
Secondary
contraction.
contraction.
What is primary contraction? Team 1.
Once we take the skin graft after harvesting, it can contract, and this is the primary contracture. And
What is
once
it due to?
the dermal content.
Team 2.
The myofibroblast causing the contracture in the wound area is called
Both are wrong.
No. What is in the derm is
Collagen and
that
elastin in
makes
the
it contract.
collagen
Elastin.
and elastin.
See, once you are saying collagen also, you are saying elastin also. What is primary contraction due to?
Ma'am, because of the elastin
Collagen?
fibers. Primary contraction because of the
Okay,
elastin
what is
fibers.
secondary contraction due to team 2?
Because of the
Myofibroblasts.
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 Now you're getting confused both which team is answering. The assessor will not know which team is answering.
Actually, myofibroblast was first told by the second team, and the primary contracture was told by the team 1.
So accordingly, you can give them marks.
half of marks you will get.
Ma'am, we'll move to the
What is-
moderator.
Time is over for panelists, and now moderator 2 minutes.
Yeah, I think the panelists have asked most of the question. I'll just
Sir,
add to
ask
that.
questions directly.
What is the principle of neck release? Principle, what you are going to see after release, what you will see, and what is the principle for?
We have to release till the all the contracture bands are released, and the chin should be parallel to the roof, and eyes should be vertical, and we should see the viable fat plane while releasing.
Any angle?
Anything. Functionally, you told what else?
Okay. What is it in
Angle,
this case?
microsternal angle should be one.
How do you do it planning in reverse in this case? How do you make it effect of this case? How do you do the clinical assessment?
Sir, we will take a person who has similar stature and similar to this person, and we will measure the cervical to head and up to the mandibular distance, and we'll calculate the apparent and true defect, and according to that, we'll measure how much raw area will be expected, and according to the raw area, whether we can get the graft or whatever is needed.
Thank you.
Then what is the tertiary contracture? Okay, I think it's done.
Judges and other seniors in the
Second team can answer tertiary contraction.
second team, team 2.
Ma'am,
Contracture into distal area causing contracture.
Primary you have taught, secondary you have taught.
Sir, you mean tertiary contracture or tertiary wound healing?
No, tertiary contract.
Tertiary contracture. Okay. Tertiary contracture is
Contracture to distal site and causing the.
So, ma'am, final contracture, which is after the skin graft has been taken up, the final contracture of the skin at the recipient site after the healing phases are over. That
Done. I think we can go.
Hello.
Hello.
Yeah,
Sir,
just
please, sir. Sanjeev, sir.
yeah, just one line or two lines from both the teams. Team A first, that about the post-operative care in contracture release of neck.
Sir, we'll immediately after surgery, we'll put a splint or mold in the neck to maintain the extension. And this extension should be maintained minimum. This splint should be continued to minimum for 6 months.
Patient should be kept in prone position with the shoulder back, without a pillow under the head.
Yes. And what about team B?
Sir, only if you think it is correct, you can ask another question, sir.
Okay. The another question, team B, is what about the late?
Now A only, sir.
A.
Not B. Team 1.
Team B. Team B.
Team 1, sir. Team 2, next 1 hour, they will be there.
Okay. So team 1 as a late, maybe say 2 months from the release and grafting. 3 months from the release and grafting. Any instructions to the patient?
To continue the splint for another 3 months, sir. It should be minimum for 6 months of splinting should be there.
6 months of spending all the time, 24 hours?
First 6 months, it will be both morning and evening, sir. After 6 months, up to 1 year, only night time is enough, sir.
You can
And you can start therapy also.
the splint only for bathing and applying moisturizer and physiotherapy for the first 6 months. After that,
Okay.
night splint.
Okay.
Okay, ma'am.
I have one question. Why you recommend the splinters for 6 months in any contracture after release?
Ma'am, generally, most of the cases, it takes minimum 3 months for the contract for anything to mature. And after that, even contracture may further develop up to 6 months.
You mean to say a scar takes 3 months to mature? How long does a scar take to mature?
21 days in the case of
Mature.
It is
Maturity,
minimum-
scar maturity. Is it for a scar maturity or anything else?
1 year.
to prevent the contracture again. To prevent the contracture
So-
again.
For up to 1 year.
So it is because of what? Recurrence is because of what?
Prevent the-
Recontraction because of secondary contraction.
Yes. So secondary contracture, myofibroblasts will be active for 6 months. So rigid splinting is needed for 6 months.
Yes, ma'am.
Okay. We'll go to the next spotter. What is this procedure and related to these questions?
Team 1, what is this?
Team 1,
meat grafting.
full name.
Team 2,
Meek micrografting.
okay. And team 1, what is the purpose of this? Where is
Whenever
it
the
used?
donor area is less when compared to the recipient area, to make the whichever resource is available, we have to take it into micro pieces and spread it over the raw area.
How much expansion is achieved by
1:9 ratio will be there.
Sorry?
1:9 ratio expansion will be there.
Okay.
9 to 10.
How is it done in two lines? Can you tell how it is done?
It's we'll spread the graft on a cartridge.
What is the cartridge
are
made
they?
of? What is the cartridge made of? Team 2. No.
Ma'am,
You see
yeah.
what you call a cartridge is actually what? What does it look like?
Dermis.
Silicon.
Sorry?
Dermal cartridges, dermal membranes.
Dermal membranes.
No.
What do you see in the picture? You can see it.
What is that brown?
These are the cartridges that you're calling them cartridges. We don't call them cartridges, but anyways, it's a kind of a cartridge. But what is it made of? Is it metallic, non-metallic?
Non-metallic.
Team 2.
No.
So what is the material?
Scaffold.
What? Scaffold. No, both of them can't answer. It's a cork. Okay. And then what is done? Hurry up because you lose out on the questions.
If you
You tell the
answer
steps.
more
Ma'am
questions,
is
you will
asking,
get
tell
more
the
marks.
steps. How it is done, tell the steps. 1, 2, 3, what is done?
Team 2.
Ma'am, graft is harvesting, then put on the cartridge, then spray, and then apply to the donor area.
No, we expand
Wrong.
No.
Team 1, it is wrong. Anyways, the other team person, team 2 wants to say something. Don't mute yourself.
After the graft is harvested, we cut into short square pieces which are similar in size to the cork.
Okay.
And then
Okay.
and then we expand the cork to the required size.
How will you do that?
How will you do that?
You are putting the graft on the cork.
mesher which increases the through the micrograph machine, which increases the meshing ratio. And then after the expansion, it increases to
How will the cork expand the graft? You have just put it on the cork and then you said you put it in the mesher, right? You mesh it.
and which ma'am, it expands with the mesher.
How will it expand with the mesher? Mesher has
Yeah,
only
all
divided
are
the
the,
graft.
all steps are there in the figure.
Everything is visible.
Everything
Be a
is
little
there.
more observant.
First, harvesting the graft, then put in the mesher and expand them. Then we have to cut down. Then micro pieces is made, put in the cut. Then we have to apply.
No.
Team one.
No.
Team one.
Let's go to back to team one. They want to add
Can you
something.
improve
Which
upon
is
this?
expanding.
Okay, now
Cork
what
is
you will see, the
Cork is
part.
Cork is expanding, ma'am. Cork
No,
is
both
expanding.
of you are
No.
not able to answer. The first picture shows the cutting of the graft when it is applied. The long sheet is put on the cork pieces, multiple cork pieces in continuation. Then you cut it as per the size of the cork. Once it is on the cork, it is put on the cork with the dermal site in contact with the cork. Okay. Then you put it in that mesher and you close it and then you mesh it. Now, once it is meshed, you open, remove the cork. Once you remove the cork with the meshed graft, you will spray a adhesive solution, which is shown in the fifth picture.
Yes.
And then you will put the
Remove the cork.
the sheet. Do you see the sheet in the sixth picture? That is the expandable gauze that has to be applied over that cork with the skin on it with the adhesive. So once that sticks to the cork, it will take the graft on it. Okay, so the graft gets transferred to the mesh, to the gauze. And then the gauze is to be stretched in two directions, once like this and once like this.
That will
once
spread.
you stretch it, it is going to expand that graft to that ratio. And then it has to be just applied over the raw area. Okay. So this you both could not answer, but that's okay. What are the other ways of expanding grafts? Or other ways of, expanding graft?
When you have less donor
This is
sites.
one way. This is one way. Okay.
What are the other methods of expansion of skin graft?
By just measuring the graft.
Meshing the graft.
Meshing the graft.
Okay. What other methods?
Minced graft can be done, ma'am.
Minced graft. Okay.
And
Cultured.
What is that? What is minced graft?
we'll cut the epidermis into very minute pieces, and we'll spray it over the donor raw area.
Are you doing it routinely?
Where are you using that?
In large burns area.
How else can you, supposing your donor area is not much and you have limited donor area, you want to cover a larger area. One is using a meat graft. You may not have a meat graft, so you can mesh it. Suppose you need a wider coverage, then what else can you do?
Stamp grafting can be done, ma'am.
Postage stamp grafting can be done. Agreed. Okay. So what are the various techniques of meshing?
Hand machine with the mesher we can do, ma'am.
Okay. And the hand mesher. Okay. Dr. Brijesh, Dr. Umar.
How much time is left, Rohit?
Dr. Brijesh, Dr. Umar, Dr. Mago.
So when it was first reported, meat grafting? Team B.
Question.
What's the
When
question?
this meat grafting procedure was first reported?
When what is reported or started, sir, means to say.
No idea.
No idea, sir.
Team 2?
No idea.
Yeah, the team 2 who is saying
Team
no,
1
both
and 2.
do no. Both are saying no.
Okay.
Now, what is the
We'll go to
disadvantage
the
of this
next.
procedure? Team 1, what is the disadvantage in our settings?
Is why we don't use this procedure? It's a very effective way of
Why
expanding.
routinely we
Why
don't do it?
Expensive, and the separate instruments should be needed. Separate cartridges will be needed. time consuming.
So cost is the main.
What is the other disadvantages?
Any other demerit of this
Graph
technique?
slouching can.
What will
Ununiform, it will not be uniform after healing, sir. Since it is uneven grafting you're placing, it looks uneven and odd looking.
What is cobblestoning?
In between the, after meshing, if put a graft, in between that bars, there will be nor hypo tissue or hypo tissue, which causes like cobblestone.
So which will have more cobblestoning of usually 1:6 mesh graft or these me grafting?
Me grafting.
Okay, who invented the meek measure? Team 2? Place? No idea. Okay. Advantage of meshing. Finish?
No, ma'am. We have 2 more minutes.
Okay. Advantage of
What are the
meshing.
other options when you don't have enough of the grafting site, donor sites? What are the options available to you? What will you do? One, maybe this me grafting, you will go for micro grafting.
Sir, non-keratinized cell culture can be done, and we can take allograft or parents graft. Parents skin also can be used for collagen grafting, or animal skin, or any dermal available.
Substitutes.
Skin can be taken from the cadavers, from the skin bank, and any skin substitutes can also be placed.
What is hybrid
And
grafting?
tissue expansion, in case of small tissue expansion, can also be used.
Which tissue expansion? Which expansion you are telling?
Tissue expansion, sir.
You can expand the skin meshed graft, but you will not expand the skin to get skin where you need, no, in acute burns. This is mainly used for acute burns or for contracture release also?
Acute burns.
It is meant only for large raw areas, which means acute burns, no?
Acutely, you cannot expand the tissues. You cannot expand the donor site. What is hybrid grafting?
Allograft with graft with collagen sheet also placed over this.
Means?
Sandwich grafting also.
What is sandwich grafting?
Also Chinese methods.
What is that?
Hello.
Sir?
Hello.
They are, I think, lost.
Hello, sir.
Team 1, Team 2.
So
What is sandwich grafting?
The sandwich grafting is when we put autograft of the patient over the bed, over which we put the allograft from the cadaver
The
of
small
this.
square pieces is put with the distance in the recipient side, and the wound area is covered with the allograft.
Sir, time up, so that now we can move to the
Moderator, questions?
Okay. I have a question. If
Team
you
one.
do a skin meshing by manually, by hand, how much of expansion you can get? How much you can get a skin expansion in a skin graft measure? And how much you will get in a micro meek skin graft?
Sir,
What you are doing?
By hand up to 1:1.5 to 2 we can get, sir. Whereas by skin measure we can get up to 1:6, sir. By me up to 1:9, sir.
So what is the advantage of meek graft? Apart from covering the big wound, what is the most advantage of this?
Less raw area we can use.
Where you get a cobblestone appearance of the graft? in a MIG graft or in case of a meshing graft?
Have you seen a meat grafted area?
No, ma'am.
No, no.
Okay. So what is the disadvantage of this micro?
Cobblestone appearance will be there.
Hmm?
Uneven surface, improper scar,
Right.
Okay.
Irregular texture of the
Okay, that's it. Or the second team can tell what is the advantage, what is the disadvantage of
MIG graft, there is no cobblestone, and we can cover the more area, and it's the costly is the main disadvantage because adhesive spray is costly.
Okay, thank you.
Even disposables also, everything costs for every session.
Obviously, the cost of the whole thing, process is very
Judges
costly.
and any other faculty.
Is the MIG grafting only MIG micrografting expansion is only 1:9 or lesser ratios are also available?
Available, sir. Lesser ratios also available.
The expansion and MIG grafting is dependent on the cork or the gauze or the measure.
Measures.
What the cork does, what the measure does, and what the that sheet does.
Measure does expansion of the available skin graft, and cork does it provides the stability to the skin graft.
Second team. Team 2, do you differ with them or same answer?
The measure do the
Measure will do the meshing part. The expansion will be provided by the gauze that we use to expand it in both the directions.
So that is called sheet.
Sheet. Yes,
sheet. So you are correct.
What exactly is the Alexander technique of grafting?
Team 1.
Team 1. You had mentioned it. Can you repeat it? Team 2.
So Alexander technique is when we use over the raw area, when we use autograft of the patient, over which we and to fill in the interstices of the meshed autograft, we place the allograft available from the cadaver or from the other person, which fills in the interstices and helps in rapid wound healing. It is used mainly to cover larger areas where we have lesser donor sites available.
Widely meshed autograft covered with allograft is a widely meshed autograft. So beyond an expansion of 3:1, 4:1, then allograft. Correct answer. I think you get consolation points. Anybody?
They will get marks, sir.
Yeah, they'll get marks.
Now we move to team 2, ma'am.
Yeah. So we have finished team 1 exactly in time. So we'll start with team 2.
Okay. Passport.
9 months child with 50% burns, involvement of face, both upper limbs, chest, back. And she came 2 weeks after the sustaining burns, 5% hemoglobin and wound infection.
Okay. How will you manage this patient?
Ma'am, first we will stabilize the patient. We'll look for the basic parameters, improve the hemoglobin, and look for total leukocyte count to look for any septic component in the child. And since it's post-burn day, ma'am, is it acute or post-burn?
It is acute, like after 10 days.
After 10 days.
2 weeks.
After 2 weeks. And we'll improve the nutrition and look for balance the input output of the child. Following which we will since it looks like second degree superficial burns in most areas, and the upper abdomen is healing or it has part of it has healed. So we will do mainly conservative management because it has more of second degree superficial burns.
Anything else that you are missing? It's a case of you have been told what?
Ma'am, of 50% face burns. So, ma'am, ma'am, what is the cause of the burns?
Forget about the cause. You are just getting this clinical picture, and that patient is severely anemic and he has wound infection. You said stabilize and you said hemoglobin you will build up. By doing what?
Staphylococcus infection because it's causing the
How will you build up the hemoglobin?
Ma'am, through blood transfusion.
What
and
blood
rule out the
do you see?
sepsis also. Because the staphylococcus infection causing the anemia and sepsis picture with the wound.
What are the signs of sepsis, burn wound sepsis?
The margin is hyperemic in the wound area with the profuse discharge is present, and foul smelling discharge is also present, and the second degree superficial wound become the third degree. The
Ma'am, and then there are clinical signs also. We can look in the for raised temperature. It could be hypo or hyperthermia. It could be tachycardia and or leukopenia or leukocytosis with increased heart rate and increased respiratory rate. And
we can
and
look
along
for
with this is SIRS, and if there is we'll do blood culture of the child. If it comes positive, then it is the definitive sign of sepsis.
Good.
can
So
look
you
for
have
the
to give all this in your management. When you are asked about the management, first you have to assess the child clinically. Okay, so you have to give. What about the signs of burn wound infection?
Ma'am, the signs of burn wound infection would be when the healing parts also get converted into deeper burns. They're not they retrograde, they deteriorate. If the, for example, in this child, when the upper abdominal wounds which are showing healing phase, if there is deterioration in that healing phase, and there is loss of the epithelium
What
as
are
well in
the
that
other
area.
signs of deterioration of the burn wound, which indicates that it's a case of burn wound sepsis?
Ma'am, pus discharge with increase in the depth of the severity of the burns. For example, second degree superficial getting into converted.
Okay, you have said that. Go on to the next point.
What is the name given to that converting second into three? Any specific name? Team 1? Just name you tell, otherwise they'll proceed. Okay, proceed.
Next, what other signs?
Yes, other signs.
multiple erythematous lesion if gram negative infection is there, satellite lesion is there, multiple in the scar there is a multiple hemorrhagic spot is there, greenish discoloration of the wound. If proteus infection is there, then is a extensive foul smelling discharge. Foul smelling is coming out.
Ma'am, it can lead to toxic epidermolysis 10 syndrome, SGS 10 syndrome in a child specifically. So we look for hemorrhagic vesicles and bullae formation also.
So these things you have to tell first regarding burn wound sepsis. So what is the greenish discoloration of the burn wound? What does that indicate?
Pseudomonas infection.
Pseudomonas aeruginosa.
Why does it become green?
Because the stain porcine stain is coming from the Pseudomonas.
Porcine stain.
There is a name in
Greenish
the
discharge.
Due to the stain.
Team 2.
Pigment pyocyanin.
Pyocyanin
Pseudomonas.
Okay. And what about the, can there be gangrenous changes in the extremities also?
Ma'am, high chances of compartment syndrome because it's a circumferential burn. So it can lead to distal. We have to check the CRT and the sensations, neurovascular status of the right upper limb of the child. So
Do you expect it after 2 weeks also? This past 2 weeks.
Not after 2 weeks, sir. 10 days.
Is there any reason other than the compartmental syndrome? What is expected is that from?
Constricting HR formation.
See, constricting HR is going to cause
thrombosis of the
blackening and
vessels.
gangrene only in the initial phase. Okay, within 2 days or 3 days, you will see that. But if it is developing after 2 weeks when the child has presented to you,
So, septic thrombosis.
Correct.
Okay. Septic thromboembolism.
Septic thromboembolism.
Thromboembolism.
Okay, Dr. Brijesh, please. And you did not mention antibiotics at all in your management. You mentioned everything else except antibiotics. Next.
So,
What is
for a
neo-estuar
child,
formation?
what method, for a child, what method will you use for assessment? Basic question. For this child,
prudent,
like 50% burns is mentioned. How will you assess? Is it correctly mentioned?
Percent.
That means to say, is it really 50%? You are seeing the face, you are seeing the torso, abdomen, upper abdomen, chest, neck, right whole of the limb. Could it account for 50% in a child? It is 9-month child.
Back also involved. Back also involved.
Back also involved. Or it is overestimation.
So which method do you use for estimation?
Broad and low chart.
Learn broader chart.
So how much is head and neck for this age group?
Head and neck is
18%. 18%.
Trunk is 13%. Anterior and posterior trunk 13. And
high leg and the head is changes according to the age. Rest area is fixed.
So upper limb would be arm is 2%, forearm is 1.5%, and hand is palm and fingers is 1.5%. Both anterior and posterior. So 2, 4, 5, 6, 9%.
No.
No, 2, 3, 4, 5,
2,
6, 7,
4
8,
plus
10%.
Okay, you have
Upper limb is 10% then.
So in this figure, do you see any warning signs? The wound is healing. Do you, in the photograph, do you see any warning signs?
Warning signs.
What is this patch called, which is on the anterior chest? You can see on the right side.
There is an infected.
Sir, whether it has converted into a deeper, it is forming into an.
Label it. What is this called? If you see in a infected burn wound, if you see this thing, what is this called? Madam was also asking the same. No. What is this called?
They are explaining, but name they are not telling.
Okay.
What is ecthyma gangrenosum?
Okay.
Okay, you have to explain that. Erythema gangrenosum is an entity where it will develop.
Okay.
Okay.
Okay, time up. What?
No, I think.
Ma'am, we have actually 5 minutes more.
Okay.
Yeah.
What are the features of a healing edge in any wound, maybe this burn wound, that you can say that this is in a healing phase?
Sir, when the healing phase the edge becomes a sloping edge with it gets the color changes to bluish, and then it changes into the pale
Whitish.
and then pink color, followed by
Discharge is
discharge is
reduced.
Yes.
Okay, what is the absolute contraindication for skin grafting of a burn wound or any wound for that matter?
beta hemolytic streptococcal infection in wound culture.
Okay, why?
Ma'am, because beta hemolytic streptococcus releases hemolysin, which causes lysis of the skin graft cells, dermal cells that causes loss of the graft eventually.
Is that in streptococcus or something else?
Ma'am, streptococcal infection only.
What about staphylococcus?
Strepto is
Team
equivalent.
2? No, team 1.
Ma'am, hemolysin.
Streptolysin.
Spectralizing do रही है.
Team 1. What is the difference in the wound picture for a staph infection and a streptococcus infection of the wound? Team 2.
Ma'am, it's a
In the staph
burning,
infection, there is a
patchy losses, which are things
patchy-
patchy,
नहीं देखा.
patchy
Say
burns.
without, before you do the grafting.
Okay.
That is after you have grafted.
What is the wound picture like? What is the discharge like? Is there any difference between the strep and staph?
In this Staphylococcus aureus, multiple hemorrhagic patches is there. Exudative wound is there.
Team 1, wrong.
There will be cellulitis, deeper infections. Patient will have septic emboli away from the region of burns.
What about the
then-
wound itself?
So can you repeat?
What about the wound itself?
The margin is hyperemic.
So angry looking wound, which is a simple angry looking wound, is a streptococcal wound. And
Can you
ma'am,
improve upon angry looking? If it is angry looking, what will happen if you touch it?
On the touch, the bleeding
it is friable, so it will bleed even on touching.
And
ma'am, staphylococcal is
so
patchy.
if it bleeds, then what can happen? What is very typical of this? You will see something. Team 1.
Okay.
Team 2.
Ma'am, multiple hemorrhagic, multiple clots will be seen.
Multiple hemorrhagic bullae.
Clots.
And staph.
And staph will have honey-colored crusts over the staphylococcal scaled skin syndrome, ma'am. It has a patchy geographical pattern of wound area is seen in staphylococcal, if I'm not wrong.
Okay, team 1. What about
Patchy appearance
slimy
in-
looking wound?
Staphylococcal.
Okay, why does the graft get lost
Staphylococcal
if you're putting, if there is staph infection and you put a graft, why does it get lost?
Biofilm will be there over the
Sorry?
which
What did you say?
Streptococcus streptolysins will be there, which will be secreted by Streptococcus, which can lead on
It
to
will not stick at all.
graft
What about
loss.
staph? What about staph then? Okay. Then staph, what happens?
Staph
That is
can-
right. Streptococcus, it will not stick at all.
Colonization and biofilm formation will be there.
Team 2.
Ma'am, it releases collagenases, which initially causes which initially looks that the graft is good, but gradually it causes loss of the graft because of the collagenase collagen degradation by the collagenases released by staphylococcus.
Okay, right.
How will you manage compartment syndrome in this child if it develops in the right upper limb?
What? So can you repeat the question?
How will you manage the compartment syndrome if this child develops compartment syndrome?
In acute setting?
Acute stress.
So we'll do fasciotomy for the child in the limb.
Fasciotomy?
Fasciotomy.
Bilateral mid.
If it's compartment syndrome, then we'll do fasciotomy. If the SR is formed, then it is eschorotomy. So in the limbs, mainly we release we will release the circumferential pressure caused by the burn wound. So we'll proceed with fasciotomy.
What are the incisions you will give?
Bilateral in the arm area, bilaterally longitudinal mid axial, and in the elbow joint we have to take the incision anteriorly, and in the forearm is also longitudinal in the both the side ulnar and radial border, and in the thumb and finger is a longitudinal, and in the palm area we can also release the carpal tunnel also.
Longitudinal
and
incision
in the dorsum is also longitudinal incision.
Time is over for panelist time. So moderator, please.
Okay, thank you very much. You have narrated nicely. I have 1 or 2, 3 questions, in fact. what are the blood investigations in this child you will do? What are the wound investigation in this child you will do?
So for the blood, we'll do complete blood count, including total leukocyte count. We'll do liver function tests, kidney function tests, uh, uh, platelet.
And how do you advise for blood test? What you will advise? For complete, what you have to write? As a
Complete
doctor,
blood
you have to write.
So CBC,
If-
complete blood count along with serum biochemistry, and then we look for serum C-reactive protein, and we'll do for wound culture and blood culture the child's
Yes, yes, yes. Somebody has told like.
and along with that,
Yes, just
serum
yeah,
serum
just one
So what
query.
will be the blood culture? In blood culture, what will be the level where you can tell the patient is having septicemia?
So more than 10^5 colony forming units, CFU.
Okay. So what about the clotting factor?
Sir,
Sir,
PTINR.
Then anything more?
So bleeding time, clotting time, and platelet count. Then we'll look for blood culture, and sir, we'll for the wound, we'll do the wound swab culture.
Yeah.
And
from how many sites you will take wound culture?
The maximum 6 sites, separate.
Is it practically done?
So practically it's not done, but practically
How many sites you will set?
Many sites.
The
So at least 3 different sites.
Which sites? From where you take? From this case?
From this.
One is the right upper limb, one is neck, and one is the chest wall.
So which shows signs of
Inflammation.
Oh.
Yeah,
So-
hello.
Yes.
Yeah, just wanted to ask them about you didn't suggest the PCT levels, procalcitonin levels.
He has told. Madam, Amrita has told earlier. Thank you so much. So,
Earlier told.
So I asked you, what is the commonest complication in this patient you are likely to have? As in complication, in this patient you can likely to have.
Sepsis and
sepsis.
poor nutrition.
Then which organ is going to be affected first? In a child, not a adult. In a born child, what is the commonest complication that can happen?
Gastrointestinal system leads to
No,
diarrhea.
no,
renal. Sir, renal.
No, in child I must.
Tachypnea, because
No. What complication? Tachypnea is not a disease or not a clinical entity. What is clinical? Huh?
Sir, ARDS.
ARDS is not also disease. What infection of the lungs can happen?
Pneumonia.
Yeah. That's all done.
Any questions?
Any other questions? I think
By
somebody was
judges and other
somebody was
faculty.
asking questions from judges side, I think.
Yes, sir. Sudhakar, sir. Are there
Not
any
able to-
questions from
Judges side, please be little louder, sir.
judges?
Yeah, just I wanted to say something that in many centers, there is intensivists and pediatricians are involved right from the beginning. So what is the practice at your centers?
Sir is managed by
So
plastic surgery.
Any
And
questions from judges?
Yes, I have already put in a question.
It is a judge question.
Judges, sir.
Dr.
Yes, judges.
What is the importance of temperature regulation in a child like this?
The child has higher chances of getting into hypothermia because of the increased wound surface area, which leads to evaporative loss, and the hypothalamic set point is changed, which makes the child susceptible to hypothermia. So we have to keep.
Correct.
How would you look at the nutrition of this child?
Yes, I just wanted to point out your resident said that they are managing 7 months old child by themselves, by plastic surgeons only, not involving the pediatrician and intensivist at all. So how is this possible to manage a 7-month child by only plastic surgeon?
Whenever the requirement.
We are involving the pediatrics unit for central line placement in a child because it's difficult for us, and for the
danger signs and for nutrition aspect, the
No, I suggest that for everything, the pediatrics in a 7-month child, somebody said, now we make the management is done by only plastic surgeons. Some of, you said it's not possible to, if you are doing it, in a, this is not good, because a pediatrician has to know the thing. A 7-month-old child, how can you will be calculating the dosage, you will be calculating the volumes, you will be calculating the output, inputs and all. There should not be any hitch in involving another specialty if the benefit of the child. That is what my suggestion and question both.
Ma'am, can we move to the next quarter, ma'am?
One question I want to ask team 2. You told the eschorotomy, fasciotomy, both you will do.
No.
So what is the difference between eschorotomy and fasciotomy? Where do you expect this compartmental syndrome? Do you expect what is the cause for compartmental syndrome if it all develops in this patient, in this child?
Ma'am, fasciotomy is done when the intracompartmental pressure, the muscle pressure increases.
Yes.
It is mainly seen in electrical burns where there is deeper penetration of the heat. So
yes, got it.
It is done till the fascia when we release the fascia and the muscles bulge. That's a sign of release of the compartment.
Then why you want to do in this case? Do you expect fasciotomy required in this child?
Ma'am, that is seen in acute burns when there is higher chances of circumferential burns.
So that is called? That is called?
That is eschorotomy, where we release the skin and the subcutaneous tissue only.
Yes, you should have clear idea what is eschorotomy, where you have to do it, and what is fasciotomy, where you will develop the intracompartmental pressure. So you should not do any mistake that I'll do fasciotomy also in this. Okay, you should think, anticipate what will be the problem for what and what you have to do. Okay, and what is the main important coverage? You, if at all available, everything for this child. Can you take autograft?
We can harvest because we can use the is a larger surface area and both the lower limb is spare, so we can use the meshed skin graft, but this area can be covered, so we can use the acellular dermis with the
which is the best, I'm asking.
Ma'am, best is the skin grafting that we need to do.
Skin grafting, but it is
along with antiderm,
along with the acellular dermis.
By doing the skin grafting, it is autograft. What you mean is autograft.
Autograft.
Are you increasing the risk of raw area in this child? Already extensive raw area is there. So what are your first foremost duties? To whether to reduce the raw area by any means or go for autografting?
We can we can debride the wound and we can assess the wound.
Already ready. Everything is ready.
We can cover the wound with the
autograft.
We can cover the wound with the acellular dermis, and we can cover the 10 to 15% of the wound area with the grafting, and the rest of the area we can cover with the acellular dermis. So we can control their evaporative fluid loss and electrolyte loss and protein loss. And in second sitting, the acellular area we can again do the grafting and the rest of the area.
What role the cellular dermis will have? It is only protection or anything else?
it protect the wound
and it causes
it
rapid wound healing, and so
prevent the wound infection also, and the
it will increase it will decrease the chances of harvesting
hypothermia also.
decrease the raw area availability and improve the healing by secondary intention also, ma'am.
I think we should go on to
Yeah.
the next case.
Next Potter. You concentrate on upper limb.
Diagnosis.
Right upper limb.
Diagnosis, team 2.
The right upper limb post-bun contracture of the elbow, axilla, elbow, and wrist, and in the left side the post-bun contracture of
Only
the
right.
axilla.
Only right.
Ma'am, left is also there.
I'm asking you to concentrate on right.
Okay. Post-bun contracture of the right shoulder joint, elbow joint, and wrist.
Right axilla.
Supposing the posterior back picture is that of a right arm only, which is of a left actually, what would be the diagnosis for the axillary contracture?
Ma'am, involving both the anterior and posterior axillary folds.
Hmm.
So it will be grade 3 if both are involved. Grade 3 axillary contracture of the right axilla and right elbow
60
with right elbow post-bone contracture.
And what if the axillary, the highest point of the axilla is free?
Grade 3.
It's only the folds which are involved.
Ma'am, if it's grade 2A is when the anterior axillary fold is only involved. Grade 2B is only posterior axillary fold is involved. Grade 3 is when both the axillary folds are involved. But the dome is in, but the axillary dome is free. And
then dome is involved.
Then it's a grade 4 contracture.
Okay. And what would be the sequence of release in this right arm?
The axilla first, and then elbow.
And
then wrist joint.
Ma'am,
or
wrist.
hand
Wrist
finger.
is, I think, probably normal. It is just that he's.
Yeah,
wrist is normal.
Why can't you release both together, axilla and elbow?
Ma'am, the we can, but the arm
Positioning of the arm.
position is difficult for the patient.
Post of splinting of the arm would be difficult to manage for the patient.
Sorry? You said splinting of?
Ma'am, splinting of both the axilla and ma'am, because the axilla requires abduction and the elbow requires splintage and complete extension. So if we release both simultaneously, then the post-op splintage of the arm would be difficult for the patient to manage post-operatively. It will be complete extension of the elbow along with abduction of the arm.
Yeah, but it's a contraction and continuity, both
Yes,
axilla and the elbow, right? So you can give him a aeroplane splint and then take it, keep it extended also to reduce the
Second,
number of
sir,
surgeries.
Madam.
Okay.
Team one,
Okay,
team one.
Sorry. Forgot. Okay, Dr. Omar, Dr. Mishra.
How will you release this axillary contracture? What are the options?
Trapezioplasty.
How will you release the axilla? And what are the options?
Bipedical release.
We can do the bipedical or trapezioplasty.
Bipedical release.
For axilla?
No, for the elbow.
Elbow.
Sir asked you axilla.
Axilla. I asked you axilla.
In the axilla, we can do the trapezioplasty.
You are seeing enough normal tissue to do something like that?
We can simply.
So incisional release and
we can do the
incisional release and grafting with the
team 1.
The end fishtailing.
Incision of the scar tissue with the fishtailing and skin grafting of the raw area.
So both of you want to go only for skin grafting?
Flaps like trapezius flap, parascapular flap.
Scapular, parascapular flap.
You want a trapezius flap there?
You
Parascapular flap.
you said that the dome is intact, right?
LD flap also can be done, sir.
With the intact dome, you would want to do a parascapular flap?
If dome is involved, you can-
Next question.
Square flap I can put.
The elbow.
Square flap we can put in case this intact dome is there. Sir.
The dome we cannot assess. So, like suppose dome is involved. So what will be your best option?
What?
If dome is involved, what will be your best option for release and resurfacing?
So then, if the dome is involved, then we can do LD flap.
If the vessels is protect.
You want
Go
to do
to the
LD
other
flap.
team. Go to the other team. Best
Second-
option, Dr. Mishra is asking you. You want to sacrifice a muscle to release a contracture?
Parascapular flap we can do. We can do.
What other option, Dr. Mishra?
Incisional release with the
Incision release with the
with acellular dermis and skin grafting.
Any other flaps that can be done? You're right. Dr. Mishra has asked you, dome is involved. You said flap, which team said? And
Lateral arm.
so the options with for flaps. Best option he asked you, you said LD, which was wrong. You said parascapular flap. What other flap can be done?
Lateral arm flap.
Lateral arm flap, arm is involved in this. I think.
The lateral part is not involved.
Not involved. Okay, what else?
A flaps can be done.
Anything else? Can a square flap be done in this?
We told my mom.
Acha, you already told.
Yes, ma'am.
But in this case, will you be able to do a square flap?
If your skin is normal, we can advance.
Anyways, the options for the elbow release.
For the option for elbow, it would be bipedical flap, bipedical release, and grafting. It would be one option.
Trapezioplasty.
Trapezioplasty.
What is the principle for a bipedical release?
Ma'am, to protect the underlying neurovascular structures, we do a bipedical release. At the site, if we do incisional release at the site over the maximum point of contracture, then it has a high propensity of injuring the
What is
neurovascular.
the principle of a bipedical release? Team 2, team 1, sorry.
Skin grafting will be avoided in the joint region.
Skin?
Joint region, skin grafting is avoided.
Okay,
The elbow
right.
region.
But what is the principle of doing a bipedical release? What is the principle? Okay. Do you do fishtailing when you do a bipedical release?
Yes, ma'am.
Team 1?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am.
Both are wrong. That means you don't know how to do a bipedical release. Both of you. Okay. If you do a bipedical release and you do fishtailing also, you are going to sacrifice the bipedical then. Okay. So that is not to be done if you're doing a bipedical release. No fishtailing. Okay. Dr. Omar? Dr. Mago?
How will you splint the elbow once you release the elbow?
extension position.
Extended arm with the
Extended forearm.
extended
Extended elbow
forearm.
position.
How long? How long will you spend?
For how long?
For 6 months for splintage. In the initially we can extended the forearms for the when the graft uptake is and heal, and then after 6 months we can only night splintage. 6 months.
When will you allow physiotherapy of the elbow joint?
Physiotherapy can be started after 3 weeks.
Physiotherapy can be start after 3 weeks.
3 weeks after
healing
uptake of the graft has been done.
What if there is loss of the graft on the elbow?
Then continue. We can do the what area we have lost the graft in the surrounding of the joint or is away from the joint. And second thing, we have to continue the splintage and no movements of the elbow joint.
So if there's significant loss of graft, then we need to do regrafting.
Regrafting also.
Dr. Omar, any questions? How many have we done? How much time left?
Only one more is there.
One more question.
One more spotter.
Okay, so is the
Time
time
is over, Rohit?
Ma'am, 2 minutes left, ma'am. We can move to moderators.
Moderator, any questions from moderator? Or we can solve the remaining.
You have told of axilla, elbow, PVC, but there is a contracture also in the chest and abdomen. Are the ears are free? Ear lobules are free? What I mean to say is that you should examine every part. What is the intrinsic? What is the extrinsic contraction?
So can we see the slide?
Go back.
Yes, ma'am.
It's free.
So the ear is free.
Ear is free.
So can you repeat the question?
Ear.
What is the extrinsic and what is the intrinsic contraction?
Sir, intrinsic. Sir, in the spot. Sir, intrinsic contraction.
All others don't put answers in chat box.
Sir, intrinsic contracture occurs because of the contracture that happened at the site. But extrinsic contracture is when it happens, it pulls the tissue, normal tissue, because of which is just adjacent to the primary contracture site.
You see the spotter and tell the answer where there is extrinsic, where is intrinsic.
Ma'am, intrinsic contracture is in the axilla.
And elbow.
And
axilla.
Extrinsic contracture would be in the
wrist joint.
Mm-hmm.
Wrist joint and neck.
Neck also.
What is the aseptic ankylosis of the joint in the ear case in the elbow? What is the aseptic ankylosis of post-bone contracture?
What is?
Aseptic ankylosis of the joint, elbow joint in this case.
Sir,
you know what is septic arthritis? You know.
Sir, because of the prolonged because of the contracture, when the elbow has been in this state for a prolonged period of time, it causes withering of the cartilage of the joint cartilage, which leads to aseptic ankylosis. Though there's no indication of sepsis in the patient, so it is aseptic spondylosis.
Yes, please. Then how do you find it? What investigation do in this case?
We'll do an X-ray.
What do you find?
So destruction of the articular cartilage with radiolucency of the joint surfaces.
Why will the joint surface articular cartilage get destroyed without the joint being involved?
Ma'am, the joint, because of the immobilization, there is loss. The movement of the joint fluid is restricted.
What is heterotropic ossification?
Ma'am, it is the ossification in the within the muscles surrounding the joint, within the soft tissues, because of the immobilization.
So if any joint is immobilized, it's going to show ossification?
Mostly it is seen in elbow joints, and it occurs when prolonged periods of immobilization is seen, for example, for 6 months.
So what is myositis ossificans? Was Madam has told already.
Yes, sir.
Myositis or
How will you treat it?
no. What is a myositis ossificans?
Sir, there is ossification and calcium deposition within the muscles surrounding the joint areas. And when the soft tissues, including the subcutaneous area, hydrotrophic ossification.
And what is the treatment?
The treatment is rigorous physiotherapy to decrease the to improve the pliability of the joint, and mainly, sir, physiotherapy is the
Team 1.
Physiotherapy is the main line of treatment, sir. And splinting.
Splinting, nahi.
So what is the commonest cause for this? How you prevent it, and what you will advise to the patient not to do?
Sir, early physiotherapy, and early physiotherapy is the main criteria to prevent heterotrophic ossification.
No, it is only massage. You should not do massage to the joint.
Okay, the next
Massage.
any questions from judges and other faculties?
Yeah.
So if there are no questions, I will move to the third spot.
Next spotted.
Next.
Okay.
What is this procedure? Team 2.
Procedure is not done, but you can do the procedure with as an indicator.
What do you see
What
on
has
in the picture?
What has been done?
What is done?
Ma'am, it indicates the areas of deep burns.
What is the procedure? What do you see? Why is it all?
The depth of the
Green.
What
Why
has
is it
just
green?
you
Blue.
explain what is done? What
Fluorescence.
has been done?
You were saying you were on the right track. You said that it's
Fluorescence.
to assess depth.
Fluorescence.
Is this fluorescence?
No.
Okay, now you're team 1.
Ma'am, it is methylene blue for an assessment of the
Burns
deeper
wound
burns. Deeper burns.
Okay. So team 2, why methylene blue is used?
Methylene blue is one of the anti-aseptic and is also a dye, and is also used to spreading area of the vascularity we can assess also along with the.
So how will you assess? You applied the methylene blue all over.
Ma'am, it sticks to the deeper dermal elements, but when we wash after 3 days, because of the hypervascularity, because of the in the superficial burns, the dye is washed off because it doesn't get the methylene blues doesn't get attached to the superficial areas which are healing. So in the
It's absorbed from the healing wound area.
Team 1. How do you assess the depth of the burn by using methylene blue?
This dye gets attached only to the deep burns. Wherever there is no
burns or anything else.
protein content.
What happened to the dye which is there on superficial burned area?
It gets reabsorbed from the continuous blood supply to the superficial due to the superficial burns and the hyperemic blood supply.
Is there some chemical reaction which actually changes its color?
In the deep burns where the protein denaturated, where the methylene blue is ionized and stained there, in the healing wound area, they can absorb and they can go into circulation. And in this procedure, we have to look for the methyloblominemia also, because methylene blue is bind with the HB and causing methyloblominemia. So we have a watch over that area also in this fluoroscopy.
Methylene blue is not going to get absorbed. It is to differentiate the depth of the burns. So why do you need to differentiate the depth of the burns? So that you can, what do you want to know? What is the purpose of doing this? Why do you want to know the depth?
To differentiate second degree deep and third degree burns, so we can plan the
Second
tangents.
degree deep and third degree deep? A third degree?
Superficial.
Second degree superficial and deep burns, so we can
So why?
plan
So that
He's
we can
telling
plan
one.
the grafting and
For
tangents
conservative and versus surgical management of different areas.
which area we have to do the
Okay.
exercise.
right. So you are right, but which area will you do excision?
Ma'am,
Which
deeper
area?
areas
Question.
which are stained with methylene blue.
Stain with the methylene
Which is
blue.
stained with methylene blue. Okay, what are the other techniques of assessing the depth of the burns?
Ma'am, pinprick test. We
Laser
use with the
fluoroscopy.
pinprick test where we if the on pricking
Stay short answers.
Ma'am, pinprick test. If it's painful, then it's a second degree superficial. If it's painless, it is a deeper burn. Then we have
laser
fluoroscopy.
In clinical, you have only pinprick test. That is the only way to decide which area you're going to excise.
Hyperemic versus pain.
For tangential excision, clinically, how will you judge?
Put the pressure over the skin, and if hyperemic, and
that
if
is,
it's
what is that test called?
Blanching and non-blanchable.
Okay, blanching, non-blanching. Then you said pinprick. Then what else?
And
anything else? Team 2, team 1?
Serial photography can also be done.
No. Clinical. Clinically.
Ma'am, color, when it is pale, it is signifies a deeper burn. But if it's more more of erythema or pinkish, then it's a superficial burn.
See, you don't say superficial. When you're a plastic surgeon, use the proper terms.
Yes, ma'am. Sorry.
Okay. Then second.
Blisters can also be seen in.
Yes. Blisters is indicative of
superficial second degree.
And superficial partial degree.
Second degree. Superficial dermal. You can say superficial dermal. That is easier to remember. Yes. Then third is, you said pinprick. Fourth, you said team 1 is. Team 2 is blanching. Then one more test. One more test. Something else that you can do.
Use the needle and stretch over the area.
No, wrong. Team 1.
Anyways. Punctate bleeding when we scratch.
No,
at the time
that is not a test. Anyways, you're done with the clinical. Team 2, what are the other tests to identify or assess the depth of burns? One is clinical. Second, you have seen methylene blue. What are the other tests?
Laser fluoroscopy.
Laser fluoroscopy.
Laser.
Theoretically.
No. Anything else you know
of?
Not laser fluoroscopy. Team 1.
Tissue biopsy.
Thermography.
Biopsy can be taken.
See, now your turn. Turn is over. Let the other team say. You said biopsy. Okay, biopsy is one of the ways, but again, we don't use it. What else?
Then dermal camera, electron microscopy, thermal mapping.
Thermal mapping, then
ultrasound and laser methods.
Laser, how do you use laser?
Optic.
Laser, team 1, team 2. You mentioned something right in the beginning when you saw this picture.
Laser fluoroscopy.
Laser, it's not laser fluoroscopy. It is laser what? Fluoroscopy is used for something else.
Ma'am, thermography. Thermography.
Green, blue.
ICG
fluoroscopy. Yes. And what else? Laser what? Laser you're saying, or both of you? Anyways.
Laser Doppler imaging.
Yeah, laser Doppler imaging can be done. Okay. Okay. Then next, Dr. Mishra, Dr. Omar, please.
Do you know of any other color dye used for burn treatment?
Burn treatment, yeah, sir. Burn. So for burn treatment or burn diagnosis?
For wound treatment, any other color dye?
Color dye, ICG.
Treatment, not used anymore.
Treatment. Dye for any treatment, any dye which was.
Iodine, providone iodine.
That is not
That's
a
a
dye.
dye.
It's a dye. It's a dye.
Dye.
Sir, junction
Any other-
violet.
Yes.
Junction
Yeah,
violet.
Junction violet, yes.
Yes.
So, and how do you prepare this methylene blue?
The methylene blue powder is coming, and we can use with the powder with the distilled water, sterile
Diluted.
distilled water, and we can prepare.
Distilled water, you sure?
Yes, sir. Because it's in the NS or RL they can crystallize, so we can use the distilled water.
Team 2, team 1.
Sir.
How do you prepare this methylene blue?
Isotonic saline.
Methylene blue mixed with a distilled water and as 1% solution.
So distilled water or anything else? This is what you have to be sure.
Saline.
It is 1 gram methylene blue in 100 ml of distilled water will mix.
Okay, where else do you use methylene blue?
Ma'am, in burns.
No, anywhere.
Ma'am, for parotid duct, to look for parotid duct injury.
The
In
marking,
hydrofacial trauma.
in the marking of the incisions.
Yes, you mark.
Mark the incisions.
In the recent guidelines, they can use in the severe sepsis patient with the additional of the antibiotics.
You use it in severe sepsis.
Yes.
Where?
People may use that. Trial.
How do you use?
They can give in our hospital the severely sepsis patient they can use with additional with the antibiotics in the IV formulation. Yes.
Local, yes, but I don't know about IV.
Maybe I have not. Maybe.
It is
Sir, you tell me
bacteriostatic.
one
It
thing.
has
What is the
bacteriostatic
basis?
properties.
What is the basic principle of all these investigations you are using for differentiating between the superficial and deep burns? What is
Sir,
the basic principle of all these investigations you are doing?
The basic principle is to look for areas which will heal with the conservative management and those which will require prolonged management.
What is the principle? What is the principle behind? You are doing any
The
Doppler, you are doing mapping.
Second degree superficial burns heal primarily with the conservatively
That
in
is
the
not the principle. What is the principle of the investigation?
The basic blood supply is available or not, and also the second thing is protein denaturation will be there.
Yeah.
And temperature will also be found out in some investigations.
The
Temperature
basic is the
will
blood
be-
flow.
Yes,
That
sir.
will tell you the temperature also, differential. That will tell you the everything. That is the blood flow basically. Whether the blood flow is flowing through which layer in the skin. That will make you wiser whether it's a full thickness or deep dermal, second degree, like that. What is the gold standard of diagnosing? What is the gold standard?
So gold standard
of diagnosing the depth.
Gold standard is tissue biopsy.
Tissue biopsy. What is the disadvantage?
But it's costly and every time it's not possible and multiple biopsies we have to take on.
What is the main disadvantage? Tissue biopsy you'll take from so many areas.
No, ma'am,
No.
it's an invasive procedure.
Invasive
so,
procedure.
That's the main disadvantage for the patient.
It can create.
And we are introducing infection also because burns is generally a sterile burns areas are there. So with the tissue biopsy, there are high chance of introducing infection into the sterile burn wounds.
One is this, second invasive, second you have to take the multiple sites.
Multiple sites.
Because burn is never uniform all over. Right?
Okay, what are the things that you will keep in mind when you take up a patient for excision? Supposing this is the patient, you have to do tangential excision. What are the things that you will keep in mind?
Stabilization, their blood
What do you
hemoglobin level.
specify stabilization?
Ma'am, we'll look for the the hemoglobin level, and after achieving resuscitation, we'll look for hemoglobin level and the platelet counts along with the
protein
bleeding
levels
and the
protein
clotting time.
levels also.
Proteins.
And a healthy donor area is there for harvesting the graft.
Okay, what else?
And
should keep something ready.
No inhalational injury
Ma'am,
is
with,
there. No inhalational injuries.
Okay, next. Just keep enumerating. What else?
We'll use tumescent solution.
It is before patient has not even gone to the OT. So before taking the patient to OT, what are the things that you keep in mind?
No any other area of trauma or any
agreed
unconscious.
What else?
And
Percentage of burn.
And
what other thing is very important before you take up a patient for excision?
Mode of injury, burns mode of
Team
injury.
1.
Hemodynamic stability of the patient.
That they have already mentioned.
Temperature.
Blood transfusion.
Blood transfusion.
The blood should be there.
You
and
have
we
to
should see
take
that
for
for
blood.
each sitting, not more than 15% of the area can be excised so that it can prevent further. And immediate after excision, we need to be sure we can close the excised area with either skin graft or allograft or what else to make it a closed wound and to help in re-ethylation fast.
Okay, intraoperatively, team 2, what will you keep in mind while you're doing an excision?
Ma'am, we'll infiltrate with the tumescent solution to reduce the chances of bleeding. And we'll use gauze soap.
Anywhere in the body?
Ma'am, not in the end arteries, not in the fingers with the tumescent solution. And then we'll use
anything else that you can use apart from using tumescent solution?
Ma'am, gauze soaked ADR, adrenaline.
Later on, once you excise. Before
And
to prevent bleeding.
to prevent tourniquet application for ma'am, tourniquet application for
apply tourniquet in limbs, right?
extremities.
If that area is not to be excised and is normal, then
And
what else?
ma'am,
what else will you keep in mind? What else will you ensure that you have to make sure that
blood loss?
Blood loss has to be what? More, less?
Minimum, less blood loss.
How will you ensure minimum blood loss?
With the tangential excision with the area, so mop is covering the tangential area and compression is given.
What else?
We can use the tourniquet if extremity areas is there.
Okay, good. Next.
We can only excise the 3rd-degree deep burns area, and we can leave 2nd-degree superficial.
Wait. Again, you are getting confused. You are saying 3rd-degree deep area you will only excise.
No, sorry, 2nd-degree deep.
2nd-degree deep. Okay. Then?
And to maintain the.
Okay, next team.
Ma'am, time.
Acha, time is up. Okay. Sorry.
Moderator, questions?
Madam, shall I ask a question or just to compile it?
Sir, question, sir.
Okay.
At the end, you can compare.
Yes. So,
Yes, sir. Any questions? Questions from judges or other faculty?
Yeah, the one question is the methylene blue 1%, which you said. How do you apply? How much time before the actual observation is marked for that? 6 hours, 12 hours, 1 hour, like that. Hello.
Yes, sir.
Yeah, do you get me? There's a methylene blue solution. First question is, have you seen this or have you done this technique?
No, sir.
Sir, no.
No, that's fine. So you're not done. So you don't know. Fine.
Sir, 1 hour.
Okay.
1 hour before.
No, not.
3 days.
Okay, go and find out. That is the way you will remember it.
Yes, sir.
Okay.
Well, one question I may ask.
Yes, sir.
What other plastic surgery condition methylene be being used?
So for
Plastic surgery
so to look for blood flow in free flaps, to look for the vascularity of the flaps.
No. For anything else. For anything lymphatic.
So for filariasis, lymphatic filariasis.
Sensitivity of
Okay. Okay.